I'd have a parent anemia. It was a whole thing. But anyhow, it paid rent for years. I think it was like 2 years worth. Like in the winter, not in the summer. Yeah. Because it was where there's winter, like in Minnesota, so. But then I moved to Indiana, and the people at the plasma center were creepy. They were like, I was getting hit on at the plasma center. I'm like, this is just weird. I'm like, this is weird.
One time I got a t-shirt and a cooler because the guy messed up on my other car. Like a stalker. Yeah, he was terrible. He's like, he got, I'm here for 2 months, and I'm like an IV needle, so I was like, I'm telling you nothing. He's like, oh, dude, good job. I shouldn't have listened to him. It was terrible.
Also, the massage school that I went to also had a nursing school in the same building, right? And so we were like the guinea pigs to like, help them,
Hey, Chris. Should I call and see if I can get in with that orthopedist?
Again?
Can I call and see if I can get in with that orthopedist?
Yes, you can try to call Sherry. I left the voicemail. Sherry called back.
You did? Okay, so then I won't worry about it.
I told them to expect your call.
Okay, so I haven't called them. Do you think I have like a minute to call or no?
Again?
Do you think, are we in the time, is it okay if I call now?
Yeah.
I'm a little antsy to,
No,
does that make sense? Is that okay?
Yeah, usually Dr. O'Donnell will get you together at home. So you know what to call Sherry and tell her.
So who is it that I'm trying to get in with?
Dr. Pinello.
Here, go through shoulder anatomy real quick. I'm gonna make a phone call.
His phone number is 547.
Is it 727 or no? Oh.
Yeah, we live in 727. I don't know if you knew that.
Well, most of the
4700.
I've lived so many places.
And then
I don't even.
And then when you die, it's extension 112 when you call.
Can you write that down? Doctor Who? I like that your writing's no worse than mine. That's my non-dominant. Okay, perfect. Oh God, they're probably going to do all the... Okay. Okay. I guess I think you can do that up there, right?
Yeah, over there.
Just hurts. Just hurts. Fucking ortho. Useless. Oh, sorry. Dang it, I just swore. Useless ortho. Alright, so we're gonna get, I'll just throw this here in case I need. Did you guys like the video that I sent? I mean, bacon is just meat. That's all we are. It's just a muscle. We're all just different types of bacon. I might too. You good? Sydney, do you want to use this or?
I like this.
Or no?
You meant the chair? Oh, that, yes.
My app?
I couldn't tell you were not plugged in.
Because I might just, because it's good to have a reference, guys. Okay, so.
Transcribe your comment on what you just said, and it said mother. Like it actually put all like symbols.
Oh my God, that's hilarious. Here, Sydney, I'll let you putz around with that if you want, and then I'll just direct Chris to. What I probably should do is. Where's that little? Oh, the little table. Oh yeah. I'm gonna direct a little bit. All right, so today it's gonna be all things shoulder. Chris is gonna. I'm gonna have him do a little bit of work.
Oh boy. Inverted.
So let's get to the basic shoulder view. And we'll go from external to internal, so we get our anatomy figured out. We'll chat about that. All right, so. I know, right? It's tough to kind of get that perfect. All right, so so the biggest thing about the shoulder is to understand if you understand the anatomy and the physics is critical. And it is like any other structure, it's connected to the structures near it, but to more of a degree, it's influenced by the surrounding structures because the shoulder joint, a joint is two bones coming together. It's not an actual joint. It's more of an articulation, which is, it's really from a scale perspective, it's closer to like a golf ball on a golf tee because the acetab or the socket. Oh my God, I'm stupid. Anyhow, the socket is shallow. And the labrum, which is the cartilage that goes around it, only provides just a little bit of stability to it. But the humerus, the head of the humerus itself, the glenoid fossa, the humerus itself is ginormous as compared to the socket. So, I guess I kind of started internally. Chris, can you come down to the? Are you dissecting?
I'm taking muscle away the outside.
Unfortunately, now I'm going to ask you to, let's go back. Yeah, can you take all that off? So the shoulder joint itself is more of an articulation. And that's really important to understand with shoulder dynamics because it's really, really the most important thing to understand. So which means in the hip joint, which is a strong, stable joint, it has 3 degrees of freedom. Kind of like the shoulder, but not as much degrees of freedom as the shoulder has. The hip joint has a nice deep socket that the ball sits in, and so a lot of the stability of the joint is conferred through the bony anatomy. The shoulder, on the other hand, has a shallow socket, a very large ball that kind of floats on that socket. And so really understanding that it's an articulation rather than a solid joint is really important because and the shoulder complex is the muscles need to not only be strong to support the shoulder joints, which also includes the shoulder blade, but the muscles need to be strong, but they also need to kick in at the right time. And that's the thing that people don't appreciate or are not always skilled enough to be able to assess, is it's just the timing of the muscle contracting is more important than the strength itself. And so drilling down, the most important little complex of muscles in the shoulder to provide health in that joint is the rotator cuff. If you guys remember, do you know the acronym for the rotator cuff muscles? The sits muscles, so that is the S is, I is, okay, so the sits, and they basically come and they come around the ball, the humeral head, and they pull it down and into the socket. I don't know how, kind of like this. So the other guys are down here. The supraspinatus is the one that's underneath the roof of the shoulder, which is the acromion. So the acromion is here. We got it? Okay, perfect. Let's let Chris see that from now. So we got the acromion is underneath, or the supraspinatus is underneath the acromion. And so can we see the shoulder blade? So the shoulder blade is kind of like this, where you've got the shoulder blade, it's in your back, but then it has that protrusion that comes forward, and it's basically the roof of the shoulder joint. And underneath it directly is the supraspinatus, and underneath that is the humeral head. And so the rotator cuff holds the humeral head down and into the socket and keeps. And so here's the acromion, and here's the ball. It keeps it down and in the socket, so that when you lift your arm, you're not crushing the supraspinatus underneath it. And so that's where an awareness of body of physics and anatomy is really critical for folks. It's a random piece of data for you. 80% of women over 70 have a shredded supraspinatus just from repetitive strain. Just a lifetime, that just shreds. It's just like a rope over hanging over the dock or a rock or something and getting pulled on. That just frays over time. So really, if somebody is older, having them do overhead activities is probably the way that they are most consistently, innocently injured. But as fitness professionals, you need to know if your patient is at risk for being injured by what you're recommending for them to do. So having older people, especially older women, doing overhead activities without being hypervigilant as to the movement mechanics of that shoulder, then shoulder complex, you can be inadvertently putting them at risk for damaging that supraspinatus, any woman who is over, let's just say over 60, just assume they have a shredded rotator cuff, or a man who's had anyone who's done any overhead activities to any consequence, if they're a plumber or an electrician, they're going to be at risk for having possibly a rotator cuff that's been under strain for a lot of years. And then the next conversation is about neck stuff, but that's a whole nother day. So just being mindful of that really tenuous arrangement with that supraspinatus right underneath that acromion, and if that rotator cuff isn't kicking in properly, that person can look really strong and like they're moving really well, and I see this in my CrossFit athletes a lot. They've got these big, strong, bulky arms, and it's kind of akin to the same thing I see in my runners. They're super strong, they can run, they're track athletes, but they can't stand on one leg and maintain a level pelvis because they don't have shit for glute medius strength. But it's the same thing for the rotator cuff. They're super strong, but because they don't do they do all the ego building muscles, so that they get the big strong muscles when they're lifting big heavy things. but the movement pattern necessarily isn't as pure as it needs to be, and so that rotator cuff becomes at risk. And so the reason I said women, yeah, go ahead.
I was just going to say, so what, I guess, do you look for that, is it just any motion upwards, is pinching it always, or is it perpetuated by more fine-tuned movement?
Yep, that's a fantastic question. I know exactly what you're asking. We're going to get there. Okay, first let's talk about women. The reason I keep saying women. Women have 40% less muscle mass in their upper extremities, so we are uniquely at risk for having for shoulder issues because the shoulder is kept healthy by the surrounding musculature. And if the surrounding musculature, you have less of it as you get older, the muscles get weaker, blah, blah, blah. And so, but that's also kind of a random factoid why women are actually, rock climbing is the only sport where women have a physical advantage to men.
Flexibility?
Well, it's complicated. It's flexibility is one issue. The where the center of gravity is another issue, and then the strength to weight ratio is favorable. Because women tend to be more, you see the rock climbers, they weigh like 4 pounds, and they're lithe and really flexible. And so it's the only sport where women physically have an advantage over men. That's your random. And then 200-mile or more races, endurance, because women have actually an advantage over men in extreme endurance, but that's a little bit more of it's a little bit less common happening, especially in this world. But okay, random. So that's a good question that you asked about the shoulder. So if we're talking about that glenohumeral joint where we've got the roof or the acromion, and then you have the ball and the humerus, if there's that little lump on the outside of the humerus, the greater tubercle, so if the ball is rotated so that bump is closer in proximity to the acromion, so that let's say this is the lump, if it comes up, then you're going to crush that infraspinatus more. So basically, if you are bringing your straight abduction, you're at more risk for crushing the infraspinatus because the greater tubercle is right, and it's perfectly lateral, and it's in line to just crush the infraspinatus if the rotator cuff isn't pulling the ball down and in. And then that is the most dangerous position, but then also if you're going straight up. And so I worked for years in the inpatient and skilled nursing setting facilities, and as a traveler, the first thing I would do, have you guys seen those shoulder pulleys? You've seen them. Yeah, they're pulleys, and there's a pulley and then a rope and a handle on each end, and you basically, this is the good shoulder, this is the injured shoulder, and you drag the injured shoulder up passively. It's supposed to help improve passive range of motion. But what you'll see is you'll see this little old lady just sitting there in a chair not being supervised, and she'll just go, ow, 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 and nobody tells her that's not supposed to hurt, and then they're just crush, crush, crush. And so it's the overhead, so it's straight abduction, and then just overhead activities can be dangerous. So the safest angle to use is what we call scaption, which is the angle of your scapula, and it'll vary a little bit according to a person, depending on the dimensions and curvature of their thorax and their rib cage. So it's so if you see where somebody's, and so it's usually about 45, so this is 0, this is 90, it's usually roughly 45 degrees, and this creates the clearest path for the humeral head to move upwards, or it actually needs to work downwards while you're moving your arm upwards. And this is also the best position where you can, because I can see all of you are doing this. You're tucking your shoulder blade down, and you're anchoring that, integrating your rotator cuff into the movement, and you're lifting the roof, and then rotating that the arm up. A sick shoulder movement pattern would be the shoulder, the upper trap, because the shoulder hurts, and then you lift, and now you've shortened that interval between the roof and the supraspinatus. And so just if you're looking at just that itself, if somebody lifts their arm up and they do this, you know they're at risk for crushing that rotator cuff. And this isn't a functional movement pattern. This is a compensating movement pattern that happened for some reason, which is something that I can, determine pretty well. But the best you can do is do right by somebody by just, can you keep your shoulder down? And if you stay in scaption with that person and train that movement pattern, shoulder blade down and then lift your arm, but keeping it not anything above 90, you can be putting somebody at risk. But just if you stay in scaption, you're safe. Does that make sense?
Yeah.
And so then the other conversation then is how that inclination, kind of in this conversation, has been how that inclination of the shoulder blade. If that shoulder blade is rotated forward, this is a rotated forward shoulder blade, and it's lowering the roof. This is a rotated backward shoulder blade, and it's increasing the roof. And so just being aware of all that is really important and can do, help you to do right by your patients or your clients a lot better. And so something else to be mindful of is that scapulohumeral rhythm. Has anyone heard that concept before? So what is it and when?
It's like it's like a certain amount of degrees, like your humerus is moving, and then at a certain point your scapula gets rotated.
Right, and so so it's the rhythm of
relationship of muscle activation and how it affects the bone, I guess.
The ratio of scapular movement and humeral movement. And it's 1 to 3, or forget. It's like for the first few degrees, it's I forget the ratio. It's the shoulder blade and then the humerus the rest of the way. So it's shoulder blade, then humerus. Like for every 1 degree of scapular movement, there's 3 degrees of.
Yeah.
I don't remember the ratio.
Right, I know it's all, but as long as you're kind of aware of it, that's probably more important than being able to barf out the facts, the data. But it's 0 to about 60 degrees, and then it's 2 to 1. So humerus moves first, and then the shoulder blade needs to kick in. So until about 60 or so. But really just being aware of that you cannot have arm movement if you're not having shoulder blade movement. And so just the biggest thing is being aware. And so that scapulohumeral rhythm is how they work together. So it's very important concept to be aware of, because then you kind of seeing that. If you're paying attention to it, then you'll see it more. And then also my personal soapbox is the neck is deeply connected to the shoulder complex. It's actually the clavicle, or the collarbone, is the only connection from the central skeleton and the axial skeleton. So the clavicle connects your spine to your appendage. It's the only place that happens. So you've got your clavicle is connected, basically to your neck. And so shearing forces that happen, like people who work in overhead jobs, like plumbers and electricians. The plumber makes more sense because, you see them laying down like this, but an electrician is doing a lot of this as well. So if they're in an overhead position with their arms, there's a lot of shearing forces that are going through the low neck, C5, C6, because of the movement of that clavicle and the shoulder complex. And so that's the kind of the unforgotten variable, is for folks to be paying attention to where somebody's head is. So if they're turtling and they're lifting their arm like this, for one, when you do this, you're collapsing your thoracic spine and rib cage forward, which brings your shoulder blade is just a passenger on your rib cage. So it brings that the shoulder blade forward, and then now you're lowering the roof. So even if you're moving your shoulder blade, if your rib cage is forward, because your neck is, and all the big muscles in your neck are kicking in, but not the neck, the stabilizers in your neck, your deep neck flexors. So if somebody turtles out and they're lifting, your shoulder's still at risk. So being aware of having a neutral neck posture is really also key, and it's something that a lot of folks really just don't pay any attention to, just because there's a lot to know. You know, like I go to yoga classes, and that's probably one of my biggest peeves is they talk about, oh, you know, be careful of your low back and let's guard your hamstrings and all this, and then they have you doing like a headstand on the wall, which is the worst. If any yoga teacher has you do a headstand on the wall, then you need to fire them immediately because they are incompetent. Because if you cannot, it is the worst thing. If you cannot do a headstand loaded with your hands, you don't belong doing one. A handstand is another story, but now I'm off kilter. But we all need to be remembering, if we want to be the best day and doing things in the best way, don't forget the neck. Best day, doing the best way. So what's that term we talked about last week is regional interdependence. So that also needs to be a core value, I think, in somebody who is looking to do things in the best way. Is we're not just looking at one body region. Even though they say their shoulder hurts, you're not going to be able to fully remediate that impairment if you're not changing that movement pattern, and that includes the joints and the muscles and everything in the adjacent areas. So thinking regional interdependence, and thinking of how the body parts are connected and the movement patterns is, for one, that's my special training as a physical therapist and why we have, you know, shit tons more going on. But that's a little bit more of my focus. But there's no reason why you guys can't be aware of the telltale signs of. And so that's the important thing, is being able to screen if somebody needs to be looked at by somebody else, referring to another provider, such as, you know, like if you're noticing somebody's like this all the time, like interestingly enough, if somebody's got shoulder pain and they're turtling all the time, it might actually be a neck issue. And that's for me to kind of figure out and to help you guys to kind of suss out. And so just knowing when a second set of eyes is needed is probably the best thing that you guys can do for your clients, is just knowing when you need to bring in just a second opinion kind of thing. And so that's really helpful. But this here is just a really common, and that's related to shoulder pain. So we got a little bit off kilter there. We were just talking about that bony anatomy, the scapulohumeral rhythm. If you're staying more in the scapular plane, I would really recommend you just hang out in scapular plane. You can be a lot more effective, and most functional movements are in the scapular plane. You're just not going to see people doing straight abduction like this ever in real life.
So why do we lift tons of weight over our head in that position?
Who lifts tons of weight over their head?
Everybody. All the bros. The bro Sidens down at the Meathead Studio Gym.
Well, because it's really effective and it gets you nice and strong. Because lifting over your head properly strengthens your entire body. And that's actually next week we'll talk about how the shoulder and the hips are connected. And that compound, because if you notice we're kind of going from we're going to go one region, and then we're going to combine the regions. And so next week we'll talk a lot about that, because it's good for you. But there's also, you know, you can also eat too much fiber too, you know. Fiber's good for you, but if you eat too much of it, you know, you can kind of blow things out in a bad way. You know, so too much of a good thing is, and so that's where that movement pattern cue, you know, being mindful of that movement pattern and balance is really important. And that's like, so if I'm going to work with a CrossFit athlete, more often than not, it has to do with a movement pattern that's impaired. It's usually because of a compensating something, an injury that happened a long time ago, or they don't focus, because it's not sexy to focus on the proximal musculature, because now we can go all the way back to our early in services talking about proximal, and when we're talking more neuro, but the same principles apply. You have to be strong proximally to have distal mobility. So, and it's the same thing with the shoulder complex. The shoulder blade is a proximal structure that needs to be strong so that you can have mobility distally. So that concept does not go away. It's a physics concept. And so just really having that integrated in sort of your eye and your understanding of things is really helpful. So yeah, it's really efficient to lift something heavy over your head, because when it's heavy over your head, then you have to kick in all the rest of the muscles in your body. So, and it also is ego rewarding as well. If you get, bigger muscles, if you're genetically predisposed to type 2 muscles and you actually get them, unlike a lot of us except for Juan in this room, we all tend to be fairly light, and a lot of it is our genetics. The proportion of type 2 to type 1 muscle fibers is a genetic predisposition. Like, you can't really help it. If you're built to be long and lean, you're built to be long and lean. You can convert those B fibers. There's 1B that can convert to type 2, or they can stay type 1 depending on the activities that you're doing. But if you're built to be long and lean, you're going to be long and lean. You're never going to become a meathead. Like Juan, we could get him to be a meathead very quickly. It would take like 12 minutes. Like Sydney, you could do the same workouts and lift the same weights, and you ain't never going to get the size of like what's one of those, who's a superhero with the big muscles? What's the one? Yeah, you're never going to get the Hulk size, no matter how hard you try, because you're just not. That's not your genetic predisposition. Is that lean endurance, But he's not going to run a marathon, kind of thing, And so, or you will, but it's going to be a different level of effort because you just got all these muscles. So we're all built kind of the way that we're built. So wait, we kind of got off track. So we didn't talk specifically about that rotator cuff, but now we've kind of talked about the basic anatomy. But also what's something to think about, which I just sort of touched on a little bit, we talked about regional interdependence, how the shoulder complex, the shoulder joint is an articulation, how the shoulder blade is kind of a part of that, and then thinking about that rib cage. So, you get folks in here, like women, if they have a sprung, this is kind of a horse term, a sprung rib cage, where if it's a bony change that is not going to be able to be reversed, then you need to accommodate that. Meaning, if the rib cage is such that this is stuck and they can't get out of this forward head kind of with that dowager hump, or even if they just have maybe some compression fractures or something in their thoracic spine, if that's a bony change that you can't reverse, then you need to just work with it. And so then avoiding any overhead kind of stuff, because they're just going to crush their supraspinatus probably doesn't exist anyways. But it is amazing how much you can do without it. Like, I can't tell you how many patients I know who don't even have a supraspinatus, and they never knew. And because their body just compensated, which is really amazing. And then here's a random factoid for you. The bicep tendon, and that might be kind of fun to go, maybe I wonder if we can you add muscles now that we got this skeleton?
I go back to, probably going back from skeleton to muscles. Do you want muscles again?
Yeah, I wonder, can we go from the inside out instead of the outside in, or is it easier to go from the outside in?
Outside in.
Okay, well, we'll do that, but I just wanted to talk about that bicep tendon for a second.
Like for a bicep tendon?
Yeah, but we can start from okay, is that easy for you? So if we take a look at that bicep tendon, which is on the right-hand side there, the long head of the bicep, it actually goes through the groove here, and it's misdiagnosed all the time by bicep tendinopathy. I get it all the time around here. For some reason, it's the in vogue diagnosis. But at least they're referring them to me eventually. So the bicep tendon comes through the bicipital groove, and then it goes, what's really fun about it is it goes up and into the glenohumeral joint and attaches to the top part of the labrum at like 12 o'clock. And so Chris is probably fairly familiar with that whole anatomy because he trashed that whole scene there. Let's get into that, where the bicep tendon attaches in the labrum.
Oh, there we go. Let's see if we can get. We'll show the.
So what's fun? So here's just kind of your random, a little bit. Okay.
In yellow.
Okay, great. So you can kind of see where the where's that tendon?
Where the tendons of those two lines.
They got the bicep, long head.
Yep. So kind of see where that bicep tendon comes into that top part of the labrum. But what's interesting is, okay, so in the weightlifting, if you have somebody do bicep curls, that bicep muscle is one of the first muscles that you can bring hypertrophy to or increased girth. And so it makes you look like you're, the person's getting super strong and all that. But that bicep tendon, going into the joint there, most people think the bicep just does elbow flexion, because that's what it crosses the elbow, and that's kind of where it is. But it does assist in the last few degrees of shoulder flexion. The last little bit, when you get up close to the top, the end range, so technically end range is it's 180 for the shoulder flexion. That last like 10 or 15, actually it's really the last 20 degrees, that the bicep tendon kind of tightens up and creates stability for that shoulder joint. But you can survive without that bicep tendon. Without that little bit of stability, but yeah, that was interesting.
What was the thing you had mentioned last week about someone who was supposed to be using a muscle to do something, but they used their bicep instead?
Oh yeah, that was somebody who had, and that was again one of my people who had a rotator cuff impairment. She had a rotator cuff injury, and her compensating pattern was to use her bicep to flex her shoulder, and not her rotator cuff, the anterior deltoid and all that. Yeah, it was interesting. Yeah, I'm like, why is your bicep firing when you're flexing your shoulder? But that's so fun how the body can really compensate and get kind of smart. And so kind of paying attention to that sort of stuff kind of brings things to another level. So rotator cuff is really focused on highly in my line of work because, it's a lot of what we do is, rehabbing surgeries and all that and you can't have mobility until you have, and the stability needs to be proximal. And so if you're going to do any strengthening, you have to be looking at those proximal structures, and the most proximal structure in the shoulder joint, if you want to talk about the joint, is that rotator cuff. If that rotator cuff is not holding the ball down and in, anything else you're doing, at some point there's going to be maybe an issue. And so the traditional rotator cuff exercises, so let's see, we've got the infraspinatus, which is here. Supraspinatus. So we got the supraspinatus, which runs, and the referred pain, if somebody talks about having pain here in their deltoid, that's probably somebody you want to refer to me to do an eval on, because that is referral pain for the rotator cuff, specifically the supraspinatus. So referred pain means where they're having an injury in one area, but they're feeling it somewhere else. And so that's really common. If they say right here in this area, that's not deltoid pain more often than not. It's the supraspinatus, and you're crushing it, and they're having supraspinatus pain. It's the way that the nerves report the pain, because internal structures, like if you're having a heart attack, you don't really have pain in your heart, so your brain gives the symptoms in a different area just because of how the neurologic connection is.
So it's just nerves alone, not muscular related at all?
It is
spinatus muscle from the supraspinatus, but the pain here is just from nerves, not from a different muscle. This is what I was asking.
Well, that's a good question. So if it's referred pain from the supraspinatus, then it's the supraspinatus is the one that is involved, not the deltoid. Does that make sense? Is that answering your question?
I just didn't know if the supraspinatus started. Oh, so it is two different. Oh, I didn't know if the supraspinatus being crushed was physically doing something else to a different muscle in here.
No, it isn't. It's just it's the way that so you have different acuity to pain reporting in different parts of the body. So if you guys have seen a homunculus, kind of off topic, not really, but if you see the homunculus, have you does that make sense? The homunculus is it's a graphic orient image of the nerve representation of different parts of the body. And so so it has really big lips, really big hands, really big genitalia, because you have more it's not about the nerves, it's about the cortex in your brain. You have more representation of those body parts in your brain that it correlates with those body parts. So there's a larger part of your corpus callosum dedicated to innervating your lips than dedicated to innervating your little toe. And so that's the internal organs in particular, there aren't any nerves themselves that are indicating specific. So if you have something going on in an organ or an internal structure, you get that referred pain where the organ's injured, but it refers out somewhere else and gives symptoms. And so the place where those symptoms are happening is not what's being damaged. It's just how the corpus callosum, your central nervous system, is organized, and how it informs that nerve signals the nerves more peripherally. It's kind of a complicated answer. So if your supraspinatus is being crushed, then the common referral pattern, which is, what's that?
I was saying that when I see the term like viscerosomatic and somatovisceral, I do not know about that when you do like organ massage on people, because you'd be on someone like psoas and you like feel in their organs, like the way the organs and cells and muscles are back and forth to each other.
Yeah, so visceral somatic just means internal body in Latin. Is the direct translation. But yeah, you can't, gallbladder pain is not in the gallbladder specifically. But yeah, so they kind of talked about the referral pain, like if you're pressing on somebody's gallbladder, they're going to feel it somewhere else. Is that kind of what you're talking about?
What was that? And then just people commonly with GI problems have low back pain.
With who problems?
Like GI, gastric issues will have low back and pelvic pain. Just that relation between your organs and skeletal muscles.
Right, yes. So the referral of pain is very common throughout the body, and that's again kind of where the physical therapy, why we have direct access now that we have doctoral degrees, because historically you would have to, if you had a musculoskeletal symptoms, you would have to go to a physician who would screen as to whether or not it was something that was musculoskeletal. And so, for instance, gallbladder pain can appear to be upper rib pain on that right side. If you have kidney injury, kidney infection, kidney tumor, it could be manifested or felt by the patient as low back pain. It can be, if you got GI issues, it can be low back pain. And so we're trained to screen as to whether or not that the pain that person is feeling is related to the musculoskeletal system versus that other structures that are medical that we can't treat. Like I had an older lady who tried to blame us. She's in a skilled nursing facility. She was the other therapist worked with her. She was discharged, and then she came back a couple days later, and she said that therapist hurt her back because she was having back pain. And it turned out, and she was really vociferous about it, about how he hurt her back. And blah, 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 and filing complaints, and it turns out she was having a gallbladder attack. And so then that's where people miss with people who don't have the specific differential diagnosis training. They can be a little bit, and so knowing when to refer is really important. Because if your training is not to diagnose, or then know when to refer. So if somebody's having, Hannah, like if somebody's having, you probably were trained that if somebody's symptoms didn't resolve over a period of time, that you would then refer them to somebody who provide that diagnosis. So that's important to kind of know. So yeah, just because they're pointing right here doesn't mean that that's what's happening. Because then it should kind of make sense to you too. Like if somebody's doing some shoulder exercises and they're doing this, and then they start saying that this hurts. I mean, if you know your anatomy well enough, that shouldn't make sense to you, because this is the lateral deltoid, and the lateral deltoid does this. And so muscles can only become symptomatic when they're being stressed, and a muscle can only shorten volitionally. So it can get stressed by shortening too much and getting tired, or it can get stressed by being lengthened too much because of an improper pattern from other muscles. So it can be eccentrically loaded too much, so it's being stretched too much. So if you know your anatomy and somebody's doing some arm exercises and then they're complaining of pain here, but you know that the movement that they're doing isn't primarily lateral delt, you should be like, well, that's weird. But that's kind of your random, so being aware of, different, and if it doesn't change, if you change that movement pattern, that's where you start wondering if it's medical, and that's where we're trained to differentially diagnose if it's a medical situation. Like somebody's got low back pain, I'll be asking other questions with regard to whether or not it has something to do with the kidneys, because the kidneys is probably the more common reason somebody's having low back pain, or if they're having something here, men, prostate, blah, blah. Anyhow, so we kind of got off track. Okay, so we got to the bicep long head, which is kind of a sister of the rotator cuff. We talked about the supraspinatus, which is like the most at-risk rotator cuff muscle, and it kind of holds it. It's the only one at the top. And then if we go to the muscles that attach, since you've got an anterior view, we want to go to the ones that attach in the front there, Chris, for rotator cuff. So who attaches in the front here? The subscap? The subscap. Huh?
Because that one, I always mix that up because the teres major starts in the back, but attaches in the front.
Yes. And so what movement do they do? No. If it attaches in the front.
Well, it depends on which way it's pulling.
Right. So we're talking about the ones that attach anteriorly.
So forward.
Subscapular. Just rotate, we call it rotator cuff?
Mm-hmm.
Subscapular.
So we've got the subscapularis. So I know it gets confusing. So the body runs along the anterior surface of the scapula and then comes around and attaches to the humerus. So if it gets shortened, if it shortens, yeah.
Like a lot of people who type all day, like just because it's like gluing your shoulder blades like down forward, not this and then that's what's
Yeah, I mean, if you're in a prolonged posture, if you're this prolonged posture, it depends. I mean, there's so much variation in how people sit nowadays. So, any of the anterior shoulder structures, if you're are at risk for becoming tight, that subscap, the teres minor, teres major, or even if you're really strong and your big muscles, like the big chest muscles, though the smaller shoulder muscles can get overpowered. So subscap is going to be that anterior shoulder blade, and then attaches at your humerus, the anterior part of the humerus. And so that's actually going to do internal rotation because of it where it is located. Right? You got it? Does that make sense? Okay. What else is anterior?
What muscles? Or are we talking
What else is connecting anteriorly? As far as the rotator cuff. No, that's good though. I like that you went.
Well, supraspinatus comes up and over, doesn't it?
Well, that's lateral.
Okay.
Yeah. So supraspinatus. We got that.
Teres major.
So teres major. Which one does that? Which way does that one go?
Wait.
So teres major. Can you show us the teres major, Chris? This is a fun one to see in climbers, especially when they're up on the rocks, because or in the gym when they're climbing, because that a lot of times you can see it just almost like an anatomy app. Like it's so super obvious. It's really kind of fun. What do you got, Sydney?
I got it on shoulder extension. It's on the teres major, and then whatever other muscles got on here.
Is that a decent picture, or you want a different angle?
Yeah, let's see from the back there.
So you can see it coming up around the front. There it is.
Uh-huh.
Oh, then is it also is that the lat? Yeah, it's lat and teres major. They both attach to the same spot. That's cool.
So that's actually considered the crutch walking muscle, the teres major, and the latissimus dorsi. It helps you do that crutch walking movement. So if it's a closed open chain, you're moving your body on your arm, and if it's a closed chain, your arm on your body. So teres what? So the
Major does this.
extension, yeah. So the teres minor is the rotator cuff one. It's the T and the sits. So teres minor. There we go. Oh, we can kind of see that. That should be pretty obvious that that's external rotation. And then the infraspinatus, it's
Pretty big guy.
yeah, the infraspinatus doesn't get injured a lot because it's fairly large. It's a big guy. So essentially, the rotator cuff primarily is performing external rotation, but it's performing straight external rotation. External rotation in that's all right. External rotation in isolation, meaning if you're going to be trying to strengthen specifically the rotator cuff, folks are usually in all the wrong positions. So you need to be elbow at the side, and then only the rotator cuff is kicking in. And it's shocking how poor that strength is. So for specific rotator cuff strengthening, you're doing just the isolated, and that's not an isolated external rotation. You're getting all different muscles kicking in there. You got your bicep and your deltoids and everything. So that's not an isolated movement pattern. Neither with you, Hannah. It's actually really it's skilled to be.
Is it even possible to isolate it completely without assisting or any other assistance from anything else?
It is possible. It is possible, but it's not really in your wheelhouse to need to be doing. like if somebody needs to be doing specific rotator cuff strengthening exercises, you probably want to be. I probably need to be on board with that because it's probably something more serious going on, because there's a whole process to rotator cuff specifically, and it's a lot more complicated with looking at that motor pattern and all that. But just being mindful of, like, So just kind of informing your eye. If you're noticing somebody is having trouble, you know, let's say they're trying to get their arm in their sleeve, or when they go to reach for things, and you're noticing that they're compensating when they're doing that, or if they're not able to, that could clue you in, hey, maybe there's something going on rotator cuff with this person, kind of thing. You know, if you're just noticing, you know, and I think the big thing with knowing anatomy and understanding like proper movement patterns and just like the dynamics of things, that really informs your eye as to, you know, referring to the correct people, but also really personalizing what you're having that person doing. And so having them do the thing that's the hardest for them is a lot of times helpful, but sometimes it's actually not helpful. And so kind of just being able to suss that out a little bit. So rotator cuff is critical for that, holding the ball down and in to the socket. And then we can expand out to all our other stuff. So the deltoids. The anterior deltoid is that big shoulder muscle that brings your shoulder forward. The lateral deltoid, or medial, brings that shoulder back, out to the side, and then the posterior deltoid is bring that shoulder into extension. That's kind of that shoulder cap there.
Sorry, I had to reset it.
No, that's fine. The bicep is considered, I would consider that a shoulder muscle to some extent, because it connects. It crosses the shoulder joint. The long head does, the short head doesn't. But it influences how the shoulder moves. But like Chris was just saying is, the muscles that affect the shoulder joint that are kind of forgotten is that latissimus dorsi, thinking about that teres major, and how they provide that stabilizing force to the shoulder blade and to the humerus as well. But really, the most forgotten are the scapular stabilizers, mostly because they're not very sexy to be doing exercises with. So the scapular stabilizers are the muscles that go between your shoulder blades, and that would be the trap complex, more so the middle trap, right? Middle and lower trap, and then there are rhomboids. And I think what we struggle with is coming up with exercises that are a little more interesting, because like people, Chris, you guys want to have some variety and do things that are interesting to people. And so just doing the classic the way to strengthen the rotator, the middle and lower traps and rhomboids are by doing your scapular retraction through doing your rows, your butterflies, and the way that you have your hand is going to change which muscle you're preferring. So it's rhomboids, middle trap. You can be doing more the rhomboids and middle trap here, where you're getting all of them. And so just being creative, you can really change that muscle just by changing kind of where the hand is. So the classic muscles are the Y's, the T's, and the W's. So the W for the scapular stabilizers, that gives several of them. The Y, the T here coming straight back, more rhomboidy stuff, and you can switch from palm down to palm up, and you're going to change which muscles you're going to be. You're going to be, middle rhomboids. And then the lower trap is the one that everyone forgets, and is probably the most important, is coming into that Y position. So this is safe because you're in scaption. It's more safe. If you're in scaption and having somebody be doing overhead, and this is hard, being able to keep your elbows straight and then straight and coming straight back into shoulder extension, that's a lower trap. And that's really something that a lot of folks just aren't doing because it's not all that sexy.
So is this pinching on superspinatus?
Not well. Would you think how much at risk is it? You're in scaption.
I don't know if going past extension, like kind of.
But how would it, if your supraspinatus is between the roof and glenohumeral joint?
Oh, so I guess
Yeah.
Right, okay, that makes sense.
So that rotator cuff is more at risk when you're straight out here and straight up.
Okay.
But yeah, no, this actually is kind of opening it because you can't really do this because you're targeting the lower trap. The lower trap is where it affects that lower scapula, and so that controls the lower scapula. So it's bringing the scapula, it's bringing the roof up and back. So the Y, the T, and the W are really helpful. And there's ways to integrate that into your, there's not a client that you have that won't benefit from scap retractor, scap stabilizer exercises. It's just a matter of having a mindset where you integrate them in. So let's kind of brainstorm a little bit how you could do something that's interesting. So I can't do them. One of my favorite harder ones, I'm going to have Juan do it. If you take the purple bands around your, let's do this. So if you take your purple band, put your hands on the wall there, and put that band around your wrists. There you go, and paste both hands on the surface. There you go. So you can do scapular clocks where you're just holding the one still and then keeping the resistance and then just moving. So this is 9 o'clock, 10 o'clock, 11 o'clock, 12 o'clock, and moving back down. Woo! Woo! That's hard, right? There you go. And then stay there, and then move the other one. Actually, everyone should try this one, because this one's actually, it's harder than it looks. Scapular clocks. Oh, Sydney's gonna grab the ballsy one, the hardest one.
Well, I didn't see any other ones.
My shoulder would explode.
Oh gosh, yeah, I can't even pull up a part of it.
But then you just wouldn't have as much range. So maybe try over there.
Oh yeah, that's a burn.
So wait, we're not done with you yet. So now you can do, so bend your elbows. Okay, so here, okay, wait, here, okay. So you want to keep the tension. So don't let it go loose. So keep the tension, and then just go 1 o'clock, 12 o'clock,
Oh, I thought it was supposed to
2 o'clock. No, it's harder to keep the tension.
Yeah, agreed.
You know how much harder that is? And are you noticing that this is similar to something else we've done for the stabilizers in the pelvis? Our abduction with squat, with abduction. So go ahead and try that one. And so the next one, to pass it off to the other folks. So, because if you do it, then you'll remember it. You're smart. You're going to go to the easier one. There you go. That's good. You see how if you keep the pressure, how much harder, that's hard, right? And then you can change the complexity of it by changing how the person, like, so this is really easy. She's got both of her feet just in a nice base. But you can make it harder by having her go into a staggered stance or a squat or a lunge. So you can play with that and make it feel like they're actually doing something difficult and interesting. And so no, that's really, go ahead and go into a lunge. A lunge is probably better because you can easily compensate if you're coming up on that. There you go. There you go. That's good. Well, that's not really a lunge because your knee is straight. So if you want to lunge, come on down and bring it into it. But yeah, so that's just an example of how things that you can do sort of modify it, but just you're getting that shoulder complex. And then don't ever be afraid to take a look as, what is happening here. And now what I'm seeing is a fair amount of winging, so that's telling me that perhaps this is not the best one for her. Because we don't want to create more winging, we want to create less winging. So, here's a fun one. Come on, Juan, I'm going to use you. Because you're life. An endurance lady. Okay, so for this one, you want to have, this is, oh my God. So you're here against the wall. So the pinkies are against the wall. And come down into a squat. All the way squat. Squat down. Now lift just one hand. No, just one at a time. And then lift the other.
Okay.
Now stand up. And then you would take like 2 steps over, squat down. Like you can work your way down. Like if you had a big wide space in the wall, you could walk down the wall. But for this one, you would just have to do that repeated. But sometimes this is fun. I'll do this for my CrossFit people and just have them going around. Yeah, you could do, because sometimes if people have a destination, they seem to feel a little bit more, right, it's a little bit, it feels like it's more doable, or that you give them a destination, do one, 5 passes. Come on down, there you go. And then with her, I'd be making sure too that we're not getting all this extension in the lumbar region, but that's kind of another conversation. So bring this part of your back towards the ceiling. There you go. Fill this space. So fill this space. Nope. Bring it towards the ceiling. There you go. Yeah, that's all right. Just fill this space. There you go. Lift your kidneys. There you go. You can some yoga. There you go. And so, there you go. Nice and straight. And we can see here now, look at how flat and perfect her shoulder blades are, because this is where the musculature needed to kick in. We've got a little bit of winging here on this left side, but so paying attention to what you're looking at too is if your goal is to get a certain muscle to contract, to work, is that what's happening? And is it happening in a way that you want it to be happening? And then you also have to work on does the client feel like they're being sufficiently challenged? And so we want to be in more of ideally if you're in more of a Y, which makes it a lot harder. And then same for you, you've got so much mobility in your low back. I've got none of that. There you go. Feel how hard that is? And so ideally what you're doing is you're doing the squat, 1 rep, come on back up. Squat, and see, right? And see, and your client can feel like they're doing something challenging, but it's really kind of a fairly low-level exercise, but it's hard to do. I think a lot of folks don't do low trap because it's hard to do in a way that doesn't feel remedial. Does that make sense? Like this doesn't feel remedial, and I would have them come only do like 1 rep of each, and then down, and then back up, 1 rep, and so down, 1, up, down, 1, up. So then you're getting squats, and rather than staying down and then repeating, because what you can do is you can create a whole lot of compensating movement patterns. So let's stay on our lower trap topic. What else can you do for lower traps in here? That's something that's not going to be lame. Or like, something that's going to be best day, kind of interesting. How about the TRX? That's my favorite for lower trap stuff. So basically lower trap, this is how you integrate, this is how you get your lower traps, is in the Y position. That is the way. Thumbs up. Woo! Wait, hang on, why are you jumping? All right, so come on, just lean back. Okay, now just keep the tension and bring, nope. So the goal is for your arms to do this movement in the Y position. Y position, oh God. Elbows straight, Y position. Y is here. Just see how it's so easy to change.
Where do my thumbs need to be facing?
Thumbs are facing straight back, elbows straight, and you're in a Y. Feel how hard that is.
So I just hold here,
And
isometric?
you're doing a little you're doing shoulder flexion, and then extension. Here you go, and then Bring your hands towards Mike.
Full.
And lower your body, and then bring your hands back.
Uh,
So bring your hands towards Mike and let your body fall backwards. Elbow straight, because that's hard. Elbow straight. There you go. Fall backwards, and then lift and bring your hands towards me. There you go. There. Now you got it.
definitely feel it more in my arms than back. Right.
All right. It just shows where your weaker places are. But she's getting good lower trap integration here. Shoulder blades are nice and flat against the thorax. So you're feeling it more here than down through here. Yeah, and that just shows, and that in doing the different multi-joint exercises shows where a person has more. Yeah, right? And that shows where a person has more weaknesses or more strength differences. So go ahead and try that. And so let's see what else. What other things you can do this with? Go ahead, Mike. Go ahead and try it.
My left shoulder is kind of janky.
Oh, okay. So then go ahead, Jose. Or Juan. Sorry. Juan. Okay.
Too much swimming.
So it's all about. So then you probably need to be doing your rotator cuff stuff.
I need to, yeah.
And then the lower trap is a hard one, and so that's more of a butterfly. So let's and see how easy it is to modify, even though we know. Yeah, so it's that straight Y. Yeah, the Y, and people are going to want to come with a wider, because if you're wider, you're adding more of the I know, right? Yeah.
Wider,
So try it.
I should probably do wider. This is pretty easy.
We'll see. There you go. It's not your lats, it's your lower trap.
No, I'm saying like this is pretty easy for me. That's really hard.
Okay, let me see.
If I bend my arms to the Y,
Yeah, so you need to keep your elbows nice and straight, all the way straight. There you go. And then come on back. There you go. Yeah, it's interesting because yeah, so can you guys kind of see her compensating movement pattern? You guys, can you see that at all? Slightly crafty compensating? Yeah. So our goal is lower trap, right? Okay, so go ahead and rest. So because that's not what you're doing, and which is why I'm saying you've got crafty compensating, which you've got fitness folks can really compensate. So the lower trap isolating exercise movement is shoulder flexion in the sagittal plane in the Y position. So it's sagittal plane only, just shoulder flexion. So this is technically shoulder flexion. This is shoulder extension, okay? So what's fun about Hannah is she's in the Y position and kind of looks like she's doing it, but you're really you're going into external rotation and abduction to accomplish that, rather than straight back and sagittal, because it's hard, because it's really hard. It's really hard. There you go, straight back. That's good. Yeah, but it's really, because that's a really hard exercise to be doing. So really, for patients, yeah, right? Yeah. That's fantastic. Hey, there you go.
It's not easy. What a high road. Well, it's like the neural part. You have to like isolate the muscle and then you're like, oh yeah, that's so nice.
And that's where it's helpful to, if you know the anatomy, you know the positions to put people in, and if you have a critical eye, you can see where that compensating is happening. So wait, say that again?
And was rowing from a high angle with thumbs down. Well, I guess that's just everything else around it.
So put your thumbs up. There you go. Is that getting her lower traps?
Yeah.
I think so.
It's not isolating the lower traps, but it's doing something. Yeah, I mean, it's fantastic. So, you know, like the most common ways to isolate the lower traps, if you're really just wanting to isolate just the low traps, is something, you know, you're doing something, they're on all fours. Yeah, I know, I was going to, and so you're here, and you're in that lower trap, and you could be adding some complexity this way, you know, and this is where you can be in a place where you're simply isolating. But what's kind of fun is you could do something on the thing is you guys don't need to be doing this specific isolating, but just being aware of how to isolate. And because that's the thing is, I wanted to talk about the lower trap because it's and the scapular retractors, because I think people a lot of times don't exercise them specifically when it's the most, having deficient scapular stabilizing muscles are the most common issue that people have. But it's the most common area people don't really strengthen because it's just easy to forget to do what to do, and then it's not always, the exercises that you think that you need to be doing aren't always very interesting. So let's talk about some more of those. What else did you have? I really like what you were doing. So come back to this and be thinking about something that you would like to do to address that scapular stabilizing complex. So, okay, so what I really like here is that how you're adding that squat in. So you can be doing the elbows down, and then as you're up, you can come down into the squat, and then come down, and then bring your arms down, up. There you go. So arms, squat, arms up, stand up, arms. But that was, the one on the wall is a little really focused, lower trap specific. This is multi-joint and this, so you're getting lower trap, you're getting all the scap stabilizers, and you're doing something that seems harder, that people are paying to come here to do something that's not easy. And you can do that in multiple different ways. So what else, what are you thinking, Mike, for a lower, shoulder scap stabilizer complex that you like to do?
Something in just like a close chain push-up type of position.
Push-up close?
Oh, yeah,
This is one I think you guys will like a lot of. There you go. Climb on that. Not you. You're hurted. Yeah. So he'll get into your push-up position. There you go. And now you can be doing just lifting that arm out into that Y position. Oh, wait. Sorry. That's not going to work. Yeah, come on in the middle. There you go. So you can be doing that there. And now you're getting core. Now come on back to the wide support. There you go. And then do your push-up plus. Yeah, push-up. And then come on up. And then plus is that protraction of the scap. So lift this, just this part of your back. So protract the scaps, squeeze the scaps together. Oh, wait, yeah. Yeah, well, because she collapsed everything else. So can you just keep all this the same, and now bring your shoulder blades apart. Apart. There you go. That's good, look at that. And now bring them together. Just them. There you go, look at how great you are, see? And then apart.
my core stable.
This is hard, right?
This is fun.
And so this can feel like it's something worth doing, right? Because the push-up plus is probably that first thing that we teach, because if you can't control your scapula, you can't learn to strengthen it, because you're not integrating it into your scapulohumeral rhythm or your movement pattern. What do you guys have for your shoulder stabilizer exercises that you like?
I said show the push-up plus, but you guys brought it to.
Yeah, you did it. No, well, that's why I did it. So what what else are you thinking? Yeah, what? What? Go ahead, Hannah. Huh?
Shoulder surgery.
Yeah. All right. Okay. Get off. Okay. What do you? So don't forget about the TRX is really magical for you all. We can really do some strong. So what do you? So from the scap stabilizers on the TRX, let's go through. Grab a hold there, Juan. And so you can do your rows.
Yeah. Rows. Sure.
The front row, there we are, and that's more bicep kind of stuff. And the anterior pec, yeah. And you can do your butterflies. So arms straight, and then bring them apart. Oh! Oh. So maybe bring your feet a little bit back. There you go. And then so you can open your chest, open your arms like a big hug, like in a big hug. That's hard, right? Okay, that's what we're doing. So we got our butterflies, and then how about if you flip it and come forward? Is that what you were thinking about? You can do, if you're doing you can do okay, yep. And then have no, come on, we're not even nowhere near done yet. So you're here, and then you can do your Ys in this position.
You can take a step forward with it.
Mommy's asking about back extensions.
Mommy's there.
So like doing some of these movements in a back extension position. I think that was his idea.
All right, Juan, see that this is great. This is our Y. So what I love, can you flip it so you're facing that direction so you're not having this in your face? So you're coming out here, and you can come out and have this arm bent and then come out into a Y with that other arm. Does that make sense? So bend the lefty, there you go, and then thumb up if you can't, or that, never mind, that's good enough. And so you can be doing here. So let me see what we got. Sydney. So that's punching. That's more distal. Yeah, no, but yeah, like I love how you think. But if you're thinking about proximal, then you're going to keep the distal stable. So bend that left one, and then bring righty out into the straight.
Start first position, then go out.
Or you can go each way, go forward, then line.
Right, but if your goal is the low trap here, so come stabilize that one, and then if your goal is lower trap, keep this elbow straight, and then that's lower, and go ahead and bend that left elbow to. See how hard that is?
Yeah.
Like this is worth doing, and you're getting lower traps.
Yeah, one bent, one straight.
Yeah, so you're and you're getting the core, and then if you want to make it harder, have them lift one foot.
Yeah, I was doing.
This is what I love about the TRX. You can do a lot, and especially if people have, like, because now you're really getting their money's worth. And then they can also be doing, like, okay, so Kwame, back.
Superman, back extensions, arms out front, thumbs up.
Yeah, so that's more of a, I hear what he's saying, so he's getting the lower trap for that one. But the Superman, it's really a very low-level exercise, and there's a lot of other things that you can do. Because Superman, you're lying on the ground, and you're just lifting your... So what he's talking about is the typical low back rehab exercise, where you're laying prone, and you're lifting, and you're doing this whole thing. This is really, yes, because you're in a Y position, you're getting the lower traps, but because you're lifting everything else, this is really more of a paraspinal, multifidi, getting the posterior chain activated, and we usually progress people out of that very quickly, because how functional is this?
I mean, when you're saving people.
If you're Superman and you're saving people, but this is where we'll teach that movement pattern, but how could we, but you're better off doing something that's unstable multi-joint, and we haven't even gone to the cable.
Oh yeah.
I mean, like the Palloff press that we were talking about last week. If you're the Palloff press, do you remember the dude? You weren't here. Let's talk about the cable a little bit, because I think that's it's a forgotten. Can we bring it down so it's 90?
7.
Yeah. So we talked about that progression for the Palloff press. Actually, who wants to do this? It's actually good for you, because no, you want both of them. It'll be good for your shoulder. So the progression of the Palloff press was first you're standing. Okay, so the progression. First you're at 90 degrees from the source. You might turn around for the camera angle. Turn and face us. So you're 90 degrees. So first you start off with where your tension and then your elbow bend, extension and elbow flexion. And you're just maintaining, it's isometric for that shoulder complex. This is a little bit more like kind of rotator cuffish. And then you can change you can change it, make it a little harder, add a little more core, and add that staggered stance, a little bit wider stance. And so that's the first one. Sometimes that's even too hard. Sometimes you just can have them be elbows straight and just walking sideways. But if somebody's, and then come on back in. So now we've got both arms. So then we've got we've got full static, and then kind of a dynamic static. And then now we're going to do the lunge, elbows straight, and go from 0 to 45. And then come on into a better lunge. Get on into a more of an aggressive lunge where you're kind of down here. Feel how...
We're going toward the machine?
Towards your midline. So you're going... Yep. So you're going from 45 to 0. 45 to 0. So I think that this one here, think about all those people who have those hypermobile low backs, thoracic regions, shoulder issues, core. That's really fantastic. And then you switch the side that they're doing it on. There you go. I don't know why this is called. I think it's a Russian dude, Palloff. But that's a whole progression. And so, yep. And this is really assisting, and to some extent, when you're coming back to 0. Wait, what'd you say? Palloff? Oh, Pavlov. Yeah. So how about... So now on the cable, if we wanted to talk a little bit more about an overhead activity that's good for that for the shoulder complex. There we go. How about a little choppage? So do one low, do one high. Because we can chop from low to high and high to low. So we can get those diagonal patterns. Are you okay to do chopping? Up high to low?
What is that?
Here to here.
Yeah, sure.
And I think sometimes like these, there you go. I think sometimes these exercises that are a little more simple are forgotten because they're not as sexy, especially like in the fitness industry. Everyone wants the bells and whistles and the thing that looks harder. But if you do this to a high degree of weight, that person's going to get a lot more benefit from it than if you're combining a few other things. Like sometimes folks, like I'll see this with like having balance discs or something underneath their feet. Well, yeah, it feels a little harder, but they can't actually lift any heavy weights if they're on a dynamic surface. Right? So that's worth doing. Try those. And so that's a sexy way to be getting, because think about it, because what's happening with the rotator cuff and the scapular complex when you're coming from high to low? You're getting concentric on one side, eccentric on the other, and then if we remember to tell them not to turtle their neck forward, there you go. Now that's hard. That's worth doing. And if that's too hard, then you can have them just do in a half squat. And so if you're in the lunge, we're getting a lunge, we're getting balance, proprioception, all of the core musculature, Shoulder range of motion, and you're not going to hurt somebody accidentally doing this. If you're doing both arms at once, the chance of injuring that rotator cuff. And this is a functional movement pattern, right?
Yeah.
And I think that if there's one deficiency that I see sometimes here, is that, or just in general, personal training, people are not having people do things that are hard enough. Like, folks need to be, especially the older population, and this is my profession, we're not so much about that anymore, but people need to be lifting heavy weights. Like, an old lady, an older woman, she needs to be doing this. Hard, she needs to be 8 to 10 reps, 3 sets, 8 to fatigue, where she's getting that type 2 muscle fibers. Because, a little bit off topic, but not really, what are the type of muscle fibers that I needed a little bit more of on Monday for when I tripped?
Type 1? Oh, type 2.
That type 2 is the fast moving, keeping me from tripping and hitting the floor kind of thing. And so the older population, they don't have that type 2 so much. So really doing, so I would only go in rather than, if you're going to do the other direction, I'd turn around. So you're always moving away from the base.
Like this way?
Yeah, so if you're going to switch directions, yeah, always be, yeah. Does that make sense? Because you can do it more, it's harder. And you can go through more of a full range that way. There you go. Yeah, and so be at a 90 degree from the base, from the source. There you go. And then really being cueing that, see if you can keep this elbow straight.
Yeah, my right shoulder is a little thinky right now.
See, don't.
I know, I gotta be doing it.
So keep that elbow straight. Hang on. Well, hang on. All right, go ahead. And there you go. So then you just want to back it up to the one where you can do it right. And keep that nice and straight. There you go. And until you can succeed. But that's interesting, that movement pattern that you have. Keep that straight. Nice job. That's fantastic. Yeah, well, we're all, I know, we're all hopefully one-handed, so, but yeah, I'm hopelessly right-handed until now, but let's see, what else do we have for, scap stabilizer strengthening?
I really like the range of motion, either back against the wall or laying down on your back. Having your elbows.
So wall slides.
Yeah, having your elbows and hands.
Yeah.
Because a lot of people just can't even do that or allow their shoulders to come flat even against the wall.
Right, and that can be helpful for diagnostic as to whether you've got a range of motion issue. That can help somebody reorder their movement pattern. Like if they're not able to, then you probably shouldn't be doing it without having me kind of check in and figure out whether or not that should be remediated or not. But that can be a really powerful way to help somebody figure out how to move that way, because it kind of forces you into moving. You have to integrate everything, right? Yeah, and so that's really more of a neuro re-ed, kind of helping you understand that movement pattern. Yeah, and that can be, helpful too for like post workout. They can kind of relax into that. So let's see, what else?
So yeah, even if you do like 10 to 15, it's very tiring.
Yeah. Yeah, but that's more the rotator cuff. I'd rather have you guys not doing the specific rotator cuff stuff, because if a person actually needs specific rotator cuff strengthening, they probably need me supervising that process. But you're better off doing multi-joint, more complex, complicated activities that are strength building, that facilitate the rotator cuff. So anything that's loaded is going to facilitate the rotator cuff. And if you've got that both arms, you're also facilitating it. So anything where you're putting weight through that body part, that's going to create that rotator cuff to kick in. So that's probably that's a better kind of something to be doing. What about something with the kettlebells at all?
I personally don't really like kettlebell swings, so.
Why not?
I don't know, just a lot of, I guess they're good, but.
Come on, bring it.
Just the hip?
I haven't thought that much into it.
I think kettlebells are fantastic and they're underused. And I think a lot of times, yeah.
Oh, I see online. People use kettlebells for everything.
Well, I don't see them, well, they're underused by, a lot of folks.
Maybe overused by people doing them properly, but underused by people that want to use them.
Well, I think they're overused. I mean, they've been the fad, and so you could say that they're overused. And then as a result, I think a lot of folks are not doing them because they don't want to be fad oriented. But if you're going to be doing, so do bilateral. Yeah. There you go.
It's the camera adds 10 pounds, you know?
No, dude, the camera definitely takes away a lot of pounds from that. That is the smallest kettlebell I've ever seen.
Why are you choosing the tiniest at all? I love the shaming that's happening. So what's great about, what's great about the kettlebell swing is that you're using the entire body.
Yes.
And you're using the entire body in a dynamic and functional fashion. And so you're using the core, and I think really just finding ways to use the whole body is really, really helpful. I think probably maybe the goblet squat with the overhead press. What is that one called, where you come down and then you add the press at the end? That's fantastic. That might be a little heavy for you, with both hands. The goblet squat, where you're here, and then come up with both of them. Yeah. With the press at the, yeah. But the goblet is you're here. So you can keep it here, you can bring it down. That's fantastic. You're getting, and I like that what you just added. So think about that, how that's getting the whole the posterior chain of your whole body.
Where, shoulders stay down and back, or when it's close to your body, and elbows are in flexion, I guess. I don't know, I was just thinking out loud. Squat down.
Squat. So do like a goblet squat, so you keep it here, so then you can come all the way down into that squat. And because actually you bring up a really nice point. So last week when we were talking about that rectus femoris and how common it is for people to have tightness, most people, like Hannah, you were talking about how people sitting at desks and those short tissue adaptations from sitting at a desk. Anytime you go into an ass to grass, you are increasing the length of that rectus femoris. So any deep squat, the more deep squatting you're having your people doing, the more benefit you're going to be doing for them. And then think about too, now you're adding all that shoulder complex strengthening. You're adding, and you're thinking from a psychosocial perspective, especially women who are older, who didn't really ever work out when they were younger because it wasn't socially acceptable. Having people lift heavy things can really change their outlook on life. They go to the grocery store and they pick up the bag with one hand and they're like, holy crap, maybe I can leave my husband. I've had somebody tell me that, because they were weak and they were in that passive mindset, and they were like, holy crap, I'm strong enough to lift this whole thing. I don't have to take his shit, I've had people tell me stuff like that. And so the kettlebells can be really fantastic, but I would does this all make sense? Notice what I'm having you do is combining all your body parts. But you can be focusing on one, but add all the others as well. And think about, if you know your anatomy, then you can get creative with what it is that you're doing with folks. Does that make sense? What else is there? Shoulder complex. So I'm thinking about that over there.
I used to do, I had this before.
Oh. I kind of like that. It's kind of like that's a nice warm up to get people to pay attention to their. Yeah, it's kind of like this where the wall slide where it gets them thinking. I kind of like this. It's kind of like a dynamic warm up where it's kind of getting them thinking about their shoulder complex. Think about those shoulder blades. Tuck them down and back. Yeah, that's actually kind of nice with a tiny little weight. How about these guys? gonna bring it out for somebody else, of course. Let's see, where are we at? Oh, poor Chris. Oops, that was my foot. Let's see. How about what about, maybe we'll bring it here so it won't slide around. How about all of the push-up variations? Who can do a push-up? Who can, you can, yeah, where you can step on and off, sideways.
Oh, yeah.
There you go.
One time I did an exercise, push-up position around the clock, and you just gotta go all the way around.
Yeah. On and off. And then you could flip it and have the feet on the higher, because that's going to be harder. And so see how you can, if you know your anatomy and what you're trying to accomplish, and try to be as multi-body part as possible. If you have your goal as to what you're trying to do with that person, that's really, and then work your way back. But then also know their personality. So if somebody's a little more burly and they want to be doing something that makes them feel tough and strong, you might, add some, do some kettlebells, because that makes them, they're manly, or maybe they're wimpy and they need to feel manly, or whatever it is. Like, just know their personality and what type of exercise is going to make them feel like they are accomplishing something. Or some people actually really like if you target the weak muscle areas and have them do activities where they fatigue quickly. Some people really enjoy that because they feel like they're getting their money's worth and they feel like they're accomplishing the goal. Other people find that humiliating, and because you can usually tell they'll make excuses if they start to fatigue and their form starts to fail, and they start, I didn't know what you were saying, or this stuff like, and that just tells you that you don't want to put them in a place where they feel vulnerable and they're potentially failing that activity, and so then you choose something what they're going to succeed at. And so it's more complicated than just I'm going to have the people do the, so having people do the same exercises all the time, you're kind of missing the boat. Think about that person, what are their functional activities that they want to be doing, and ideally you have whatever you choose them to be doing resembles that functional activity. So if somebody's they're a runner, you want to have them be doing things that are running. Somebody's going to do, if they want to be, they're a tennis player, you want to have them be doing things that resemble tennis playing, or if it doesn't resemble the activity that they want to be doing, tell them why. I know this might seem like it doesn't make sense. You want to get back to running, but I'm having you do latissimus dorsi strengthening, and then you can show them that weird little video, the guy with no legs, about how that, and just be like, you need to, and understanding. But I think the TRX is really powerful, especially for folks who can't get down into a deep squat. Because what's the most common issues people are coming in for? It's that the valgus with the femur, shortened rectus femoris, deficient strength in their scapular stabilizers. And if you integrate those components into everything everyone's doing, then you're going to be, kind of killing as many birds with one stone. Anything else for scap stabilizers?
We've been doing a lot of pushing and carrying and putting things up. Are scap stabilizers important when I'm doing a pull-up or a pull-down?
Oh yeah, of course. Yeah.
All right.
Yeah, I just wasn't thinking that at that high level.
Boom. All right. Let's hang some things.
So doing some pull-ups. And so what's really fun about this is you can be here and we're getting lats, but if we bring your knees up, we're getting core. And so they can be doing core exercises and they're doing an isometric of everything else. And bring your knees up. There you go. And you can just be doing, so what Hannah, you were just doing just a straight lat. That's just straight, she's lifting just with her lats. Yeah, so no, that's great. And it brings out the range and confidence. Somebody, even if they don't have a lot of strength, they can still hang for a little bit and be able to bring their knees up and be able to get that core. My goal was to be able to finally get to be able to do a pull-up, but it's going to be a while yet. But yeah, even if somebody doesn't have a lot of strength, They can, and then how do we modify that? You can add the strap, or you can guard them, you can have a stool right there, that kind of thing, yeah. Yeah. What else? Does that give you a lot of things to kind of think about for different exercises?
Individual back contraction.
He's getting a little bit of shoulder. Yeah, that's nice. Hey, you got it. Did it creep you out? I do too. Same thing happens to me. Like, I can't.
There's no reason. I have like a 20-point vertical that
Yeah.
I'll do once you go.
Yeah, but it's funny that what we get scared of. It's funny. When I first started CrossFit, like when I first was trying to do box jumps, I was terrified. I don't know why. I just seen too many of those videos where they crush. And finally the guy was just like, "What is wrong with you?" I'm like, "I don't know. I'm just terrified. I've never been an athlete. I've ride horses. Like I can do stuff on them that would terrify normal people." But all he did was put just one weight down on the ground. It was like this big, and I was like, "Oh, I got it." Psychologically, it was so. People are fascinating. So, yeah. So don't be afraid. I think the take-home messages are just continue. Like the more you know your anatomy, the better off you can be. You can be specific about what your interventions and your recommendations to your clients. So you have to know your anatomy. And then if you're doing multi-joints, multi-parts of the body exercises, for one, the chance of somebody getting injured as a result is significantly reduced. For another, the person's going to feel like they're actually doing something hard, because they are. And then from a third perspective, I feel like I'm doing something hard, and it's functional, because we use our whole body all day. Like even if you're getting laundry out of the laundry bin, you're doing what? We're basically doing a curtsy squat, right? And we're leaning down, and we're doing a chop up onto this. So we're curtsy squat up, so the functional aspect of it is really important, and when people realize that that's translating into their functional activities is really powerful. So have people do hard stuff. Bye. But you don't have to be so, I think sometimes people will add things that seem like a bell and whistle, but really they're just confounding the whole activity. It seems like it made it harder, but really it just made it look interesting. And so just have a reason for why you're doing what you're doing. But yeah, good times. All right, shoulder. Hey, bye guys. And so next week is shoulder, hip. So we kind of touch hip shoulder exercise, hip shoulder complex.
For next week.
So that next week we kind of touched on it a little bit with the cable stuff, but there's so much more you can do with the cable that people don't use.
We can do follower during our feed.
Oh, fantastic!
Thank you.
Welcome. Have a good one.
That makes sense. Seems like you're engaging muscles you don't use a lot.
Yeah, I like that. I have like a 4-inch vertical. There, that's all I got.